Good evening, to all of our doctors who have joined us today. Thank you so much for taking the time to join us. And like I said, I hope that all of you all are being safe and that you all are healthy, you and your families included. Today, we have got two topics which are of great importance, especially to many of us who are practicing at rural areas. Two emergency situations. One would be on how the management of snake bites in a rural area. And the second is diagnosis management of acute MIs. Today, we have got two speakers and a rather good balance of them because one of our speakers has done his entire medical education at St. John's, while the other speaker has done no medical education at St. John's. But both are very eager to join to share their knowledge with us. So without further ado, our first speaker is Dr. Jobin James. He is a Johnite through and through of the batch of 2008. He did his rural bond at St. George Hospital and Palliative Care Center at Wycombe. And after that, he did his MD in emergency medicine at St. John's. He currently is working in the emergency department at St. John's. Our second speaker is Dr. Chaitanya Harita, who has done his MBBS and his MD from KIMS. He's currently working in the Department of Medicine and Hematology at St. John's, and he has a very keen interest in hematology, and he does enjoy teaching. So without further ado, we will first have Dr. Jobin, who will speak to us on snake bites. And following that, we will have Dr. Chaitanya, who will be speaking to us on acute MIs. As we did last time, we will have a question and answer session that will be there at the end of both talks. So it will not be in the middle, it will be completely at the end. So whatever questions you have, please keep them on hold and send it to us once the question and answer portal opens up.
They can put it in the chat box in case they want during the talk.
Yeah. Yes, you can do that.
There's a Q&A box, not the chat box. The Q&A box, yeah, please.
Which is at the bottom of your screen next to the chat button. All right. Okay. Dr. Jobin, are you there?
Yeah. Am I audible, sir?
Yes, you are.
You can put on your video also. Yeah. We will put our videos off.
Yeah. Yeah. So good evening, all. And first and foremost, I would like to thank the entire Alumni Association for this opportunity. And today's topic for our rural outreach webinar, the first topic I would be talking about is snake bite in rural areas. Now, this is a very sensitive topic and something which we all should know about, since it's a very common topic that usually comes to our emergency department. Now, even besides emergency, when you're going to a rural setup also, remember many of these presentations, we might often be skeptical about them. We do not know how to start the treatment. What is the actual dose? Because many of these patients, they present to emergency and they might say history of bite or history of something else. We do not know what kind of bite it is. And it might be, become a little more diagnostic confusion might arise. So in order to find out the exact approach, we'll continue with this thing. Hello, am I audible?
Yes, Jobin. Okay.
Yeah. So this is the first case. Now, what I've shown here is a case scenario. Now, this is not a hypothetical scenario. This actually came to our emergency department. Now, as you can see from this history, a 13-year-old boy who presented to the ED with complaints of sudden onset of abdominal pain after coming from school with nausea and vomiting. Remember, this was the only history that was provided to us by the parents. And even the child himself said that that's all, only nausea and vomiting with mild abdominal pain. On examination, as you can see, there was pain in the upper abdomen and in the periumbilical region with severe dull aching pain. Now, all this history, then the vomiting, the non-bilious history, and all these things pointed more towards history of jejunoileitis/pancreatitis. And the patient was admitted to the pediatrics ward with this diagnosis. Now, if you realize this child was gradually deteriorating in the ward. Over the next 24 hours, the child started developing melena and hematuria. The very next day, it's in the evening, around 24 to 36 hours post admission, that the doctors realized that there has been swelling, which has slowly started to increase on the left lower limb. With that one, they made a provisional diagnosis of snake bite. They gave anti-snake venom. An appropriate treatment was given with dialysis and ASV, and finally, the child was finally discharged from pediatrics ward after around 1 week, around 10 days actually. Now, this is a situation that I had also in Vaikam while doing my bond. Patients usually come with very vague complaints. The most vague complaints, such as just abdominal pain or nighttime, they suddenly started developing breathing difficulty or any limb weakness. When you hear sudden onset of weakness, sudden onset of some altered sensorium, sudden onset of abdominal pain, one of the differential diagnoses that should always be kept in our mind is a snake bite history. Now, we'll go to the topic. Now, before we go to the management, a brief introduction. Now, as you all know, snake bite is a major public health problem in India with a very high mortality rate. Now, as per the documentation, only 7 to 15% of all the snake bites in India are actually documented. Why? Because in many of the rural areas, most of the people who have a history of snake bite, either they completely ignore the problem or they go to local homeopathic or local physicians. So therefore, they do not get reported. So as per the WHO, there is a gross underestimation of snake bite cases coming from India. And that too, among the documented cases in India, the highest incidence of snake bite was found in Tamil Nadu, West Bengal, Maharashtra, Uttar Pradesh, and Kerala. Now, there are various factors which usually influence the snake bite presentation in our country, mostly with respect to occupational disease, seasonal variation. Now, as evidently, males are bitten twice as often as females, mostly because many of these people who are bitten are usually from a village setup. And many of these history usually come from a field per se. Lower extremities more than the upper extremities. And one thing to be noted in mind, the crates usually have a nocturnal tendency. So a nocturnal history of bite points more towards crate. It's not the specific to crate, it points more towards crate. Now, coming to the common snakes in India, we have the most 5 common ones, which are the common cobra, common crate, Russell's viper, saw-scaled viper, and the newly discovered one around for the past 5 to 8 years, and which is being studied more, is the hum-nosed pit viper, of which cobra and crate belong to the Elapidae family, and the last 3 to the Viperidae family. Now, I am not going into detail about the differences between a non-poisonous and a poisonous snakes, but one thing that I would like to signify or point out is basically the fangs. Remember, in a poisonous snake, 2 fang marks may usually be seen. Again, it's not specific, it is usually seen with or without the marks of other teeth. Whereas in a non-poisonous snake, you might find the presence of multiple other smaller teeth marks. Now, this is one way in order to identify quickly between a poisonous and a non-poisonous. Now, this is just based on the physical findings present on the patient. Remember, around 60 to 70% of all the snake bites that present are usually from non-poisonous snakes and not poisonous. So remember, in all these presentation, if you can see whether it is non-venomous or venomous, a common presentation among all the patients is fear. All right. Where the local and systemic manifestations, though, are more predominant in venomous snakes, whereas local pain or swelling may be are usually absent in case of non-venomous snakes. This is just me trying to explain the difference between poisonous and non-poisonous. The different classes. I'm not going into detail about the families of poisonous snakes. Now, first one would be cobra and crate, predominantly neurotoxin. Now, what they do is it blocks the acetylcholine receptors at the synapses. Now, remember, when you're talking about a neurotoxic snake bite, there are of 2 types. One, they can be presynaptic or a postsynaptic mechanism in which the neurotoxicity affects. Now, what does it cause? It causes neuroparalysis. Remember CK, cobra and crate, which usually causes neuroparalysis. Symptoms would be ptosis, diplopia, dysphagia, neck muscle weakness, respiratory paralysis, and flaccid quadriparesis. The other common one would be the vipers. Vipers are extremely hematotoxic. So it usually causes necrosis, causing local swelling, Some species of vipers, especially Russells and all, may have symptoms of neurotoxicity also with neuromuscular paralysis. But the most common symptom is a hematotoxic features such as coagulopathy, DIC, and renal failure. And remember, in Indian setup, they have found out that 50 to 60% of the bites are usually from poisonous snakes are from hematotoxic snakes. Now, why are the manifestations present? Remember, the snake bites, the local and systemic features of a snake bite are basically caused due to the enzymes and various substances present within the snake venom. The snake venom has various proteinaceous compounds, organic and inorganic compounds. All these are responsible for the systemic and local effects of a snake bite. Now, as per the studies, they have found out that there are various constituents in the snake venom that is responsible for all these effects. Now, these are from the various studies. What I would like to show you is basically a phospholipase A2 toxicity, and this is basically metalloproteinases, serine proteinases, and three-finger toxin. Now, these are all specialized type of proteins which are found in the snake venom. And all of these are responsible for the various systemic manifestations and local manifestations of snake bite. Now, how about these toxins? As I have mentioned to you, there is neurotoxicity. Neurotoxicity which can act at the level of the presynaptic membrane or at the level of postsynaptic membrane. The others, it could be myotoxic, where it acts on the smooth muscles. Then there might be various other systemic toxins where it usually interferes with the blood clotting, causing DIC and hemorrhage. Others, it usually targets the coagulation pathway. The others are basically the various metalloproteinases and which have various other ACI and natriuretic properties which causes cardiotoxicity. Now, this is a very important thing. Now, potency of snake venom. Now, this is very important in order to understand why we give the dose of a particular dose of anti-snake venom. Remember that among these, the Naja, that is the Indian cobra, the krait viper, and the saw-scale viper. These are the four most common species. Remember, look at the fatal dose. The fatal dose for these all come around to an average of around 6 to 12 mg. Now, this is 12 mg for Indian cobra. Remember, per bite, the dose that is delivered is maximum for a Russell's viper and an Indian cobra, both for around 60 and 63 mg. Just note that in mind because this is the basis for which we give an anti-snake venom. And if you notice in this thing, the most fatal period is actually for an Indian cobra with an average fatal period for 8 hours. Now, when you're talking about potency of snake venom, some things to be kept in mind. Remember, there is something so-called as a dry bite. Many of these poisonous snakes, even when they bite a person, they may not show the features of any local systemic envenomation because they actually haven't released the venom into the circulation. That is called as a dry bite. Now, in some cases, even though the average, this is the average dose, in which all conditions can the snake deliver a higher dose? One, it could be when there is multiple bites. One. Two, when it is a snake that is actually starved for a long time. So a snake that has been starved for more than 5 to 6 days or 1 week, when it bites, it has a higher potency and it has a higher dose, which is dose that is injected into the systemic circulation. Third one, baby cobras or baby snakes, which usually have a higher potency of snake venom. Now, diagnosis. Diagnosis, first and foremost, is history. Always ask for a careful history, find out what was the event and how the symptoms evolved around it. As I showed you in the first example, what happens in many of our practices is that we usually miss the event because event might be suddenly that the patient might have been sleeping or the patient must have been walking in a field. The first case where the child was just walking back, the child didn't even notice that there was a bite onto the leg. So many a times we miss the event. So many a times we have to try to collaborate between the symptoms and the event in order to find out the history, in order to elicit the history of snake bite. Now, when you're looking for examination, you're looking basically for two features. One is the neurotoxic features and the hematotoxic features. So you look for various findings such as ptosis, pupils, neck muscle weakness, and examination of the bitten part. You look at the level of edema, bulle, gangrene. One important thing is you note the extent of the swelling. Now, in a rural setup, imagine a patient has come to you and there is swelling, say, up to the level of the ankle or maybe the lower level of the calf. Mark the area with a pen. Just write with a pen or something, just to draw in the area at which you find the swelling. Every 15 minutes to half an hour, you try to notice the progression of the swelling, because progression of a swelling is a marker for initiating ASV, which I will come to in the coming slides. It means that the systemic features and the local features are actually becoming more pronounced. Therefore, intervention is necessary. Now, this is something which I want all of you to remember is the 20-minute whole blood clotting time. It is a reliable test of coagulation, especially for all the hematotoxic takes bites. Now, what you take here is that you take some amount of blood and you put it in an inert substance, basically a glass tube, so that there is no further reaction. And you put it in there and you do not shake the tube, you do not touch the tube, you place the blood in the tube, and after 20 minutes, try to tilt the tube. In a normal person, the complete blood should be clotted. Now, even at the end of 20 minutes, if the blood is not clotted, it means that it is an incoagulable blood. Incoagulable blood is a diagnostic of a viper bite. So this is something that we do bedside and must be done even in a rural setting. So any patient who presents to you, one investigation that we do bedside is a whole blood clotting time, which can be done without, you do not need anything. Just take little blood and put it in a sterile glass bottle. And remember, whatever be the history, even if you do not suspect anything, remember all the patients should be kept under observation for a minimum period of 24 to 48 hours. Now, this is a big slide. Now, what I want to show is basically symptoms of envenomation. Now, here, this is basically from the API Society, where they have said the assessment of severity of envenomation. No envenomation, mild, moderate, and severe. Remember, an easy way or to assess the degree of envenomation is to assess the progression. One. So note these 3 points. One, if the swelling has involved more than half of the bitten limb, then it is an indication that it is a severe envenomation. If the progression of the swelling is rapid over a duration of a few hours, then it is again a marker of severe envenomation. 3, if there is a tender lymph nodes draining that particular limb, a presence of a tender lymph node, again, it is a sign of severe envenomation. And the 4th one, any frank bleeding or neurotoxic features is directly suggestive of a severe envenomation. Now, these are just the general symptoms, as we all know, can present with both neurotoxic and hematotoxic features. Some lesser known features are basically, which do not present commonly, are basically gastric and intestinal complaints. There are even reports in which patients have presented with history of necrotizing pancreatitis and which has been completely missed. So remember that they might present even with atypical symptoms such as maybe icy bleed, which might present as seizures, epilepsy, loss of consciousness, and abdominal complaints such as nausea, vomiting, and pancreatitic kind of symptoms. All others, since they are quite frank and which we know from the pathophysiology, we might remember these quite easily. Investigations, what we do in a bedside, are basically whole blood clotting time. Now, if you are a hospital where you have further facilities, the other things that you can do are actually blood grouping and cross matching, especially if the platelet count is low and there is frank bleeding. 3, to look for hemoglobin and elevated PCV. Why is the PCV elevated? Because there is increased capillary leakage. Because of increased capillary leakage, hematocrit is usually high in case of a snake bite. 4th one, there might be relative leukocytosis. Now, 5th one is thrombocytopenia. Thrombocytopenia of less than 1 lakh is another indication for actually starting ASV and to suggest that there is signs of severe envenomation. The ones which I marked in red are the ones that are most important, especially in the setting of a snake bite. That is whole blood clotting time, PTINR APTT, basically where you're looking for the coagulation profile where there is abnormality. 3rd one is thrombocytopenia. And if there is symptoms of, if you have an ABG machine and all, you would find out that there would be such symptoms of hyperkalemia. In a setting where you do not have a blood gas, remember to do an ECG in order to look for features of tall T waves, and other symptoms of hypokalemia. Now, how do you manage a snake bite in a rural setting? Now, first one is field management. Remember the mnemonic carry, no, write. This is what is usually followed right now. So if there is a history of any snake bite, number one, do not allow the victim to walk even for a short distance. That is what is carry. No is do not apply any tourniquet or electrotherapy or cutting. Pressure immobilization may be given, it's again controversial. 3 is reassurance. Remember, most of the snake bites are basically from non-venomous species. Only 50% of the bites can actually envenomate the patient. I is immobilize the same way as a fractured limb immobilization. GH, which stands for get to the hospital, and T, tell the doctor of any symptoms that happened, which was actually on the way. Now, these are the must. I think we all of us actually do know all these things, but still, to emphasize, do not apply a tourniquet. It is funny that even now, many of the patients, even those who are coming from primary healthcare centers, when they present to the emergency, actually come with a tourniquet in place. So that is something which should be completely avoided. Do not apply a tourniquet. Now, some people say they have applied tourniquet as a kind of a pressure bandage. Remember, pressure bandage is completely different from tourniquet, which I will show you in the next slide. So do not apply a tourniquet. Now, if the tourniquet is present, remember, connect the patient on the monitors, look at the heart rate, the saturation, and the respiratory rate. Tie a BP cuff above proximal to the site of where the tourniquet has been tied. For example, if the patient has come with a tourniquet in his leg, at the level of the thigh, you apply the BP cuff. Inflate it to a systolic more than your systolic blood pressure. And then you remove the tourniquet and you gradually deflate the cuff. You gradually deflate it at a rate very slow. You can do it at around 2 to 5 millimeters per every 10 to 15 seconds. Why? Because you do not want the snake venom that is within the venous circulation to completely get released into the systemic circulation. One, do not wash the bite site with soap or any other solution to remove the venom. And the others, do not apply any cuts or incisions. We know these are we have learned all these things in maybe time, but still many of the patients still come with such history. And I would like to emphasize, do not take to quacks. Even now, in many of the bone centers, many of these patients will come with a green colored charcoal or green colored substance where they will put it over the site of the snake bite and they would have tied it there. And their philosophy is that it would absorb all the snake venom. Remember, it is precious time that has been lost. So do not do all these things. Now, as I said here, this is something which I called about pressure bandage. Now, if there is when you're taking the patient to a higher center or to a PHC and you have witnessed a snake bite, remember, apply a broad pressure bandage from below upwards, like how you would do regarding an ankle strap or an ankle bandage, crepe bandage. That is how you would apply a pressure bandage, and that one you have to splint to the leg such that you are immobilizing it. Post that, you would take him to a higher center. Now, how do you manage at the hospital? Remember, since I am pretty sure all of you have done your emergency posting. Remember, emergency posting, the approach that we always do, A, B, C. That is the best way to approach any patient, irrespective of if it's a snake bite or anything else. Remember, you will not miss anything. First one, airway and breathing. So provide intubation or positive pressure ventilation if the breathing is compromised. Now, in a rural setting where you are obviously you cannot do intubation, but one thing that we would strongly suggest is putting a bag and mask ventilation. Remember, intubation is not the final pathway. Remember, your idea is basically to provide adequate oxygenation and ventilation. In cases where you are not, if the patient is completely paralyzed, you can put an oropharyngeal airway or a nasopharyngeal airway and continue with your bag and mask ventilation. 1. 2. Look circulation-wise, look if the patient is in shock. If the patient is in shock, connect large 2 IV needles and you give NS bolus of around 1 to 2 liters. In an adult, it will be around 20 to 30 ml per kg bolus. Remember, shock in a setting of a snake bite is usually treated as kind of a septic shock, because it's more of a distributive, similar to a distributive shock. Tetanus toxoid if the skin is breached, and antibiotics, which I'll come to in the coming slides. So primary survey when the patient comes. One, the patient is presented to your clinic. Is the patient able to speak properly? If he is able to speak, tell his name properly, and if there is no secretions or no noisy breathing, it means that his airway is patent and it's holding good. Second one is breathing. Look at his respiratory rate. Look at his saturation at room air, respiratory effort, and neck holding. Remember, a poor neck holding actually means that there is rapid ascension of his paralysis. So it is something where he would require ventilatory support. The other one is maybe single breath count. Again, which assesses your diaphragmatic strength and will help you to analyze whether his airway and breathing are intact or not. And the other one would be your circulation and disability. Remember to always check your GRBS. In many of these patients in the night time, hypoglycemia is a differential for a rapid onset weakness where you have to consider hypoglycemia. So check GRBS also in such patients with pupils and GCS monitoring. What do you give for pain? As soon as a patient comes to your clinic, he might complain of severe pain. Remember to give him adequate analgesia, which can be paracetamol followed by tramadol, which is an opioid. Second one is handling tourniquet, which, as I said before, remove the tourniquets slowly. Now, the third and the most important one, which everyone should know, is the anti-snake venom. Remember, it is the only definite treatment of a snake bite. Now, what happens is that there is a circulating venom in the blood and the tissue. And this anti-snake venom is actually enzyme refined fragments of IgG, which actually bind to it and thereby reduces the circulating venom. In India, there are two types of ASV. There's a monovalent and a polyvalent ASV. In India, what we have is basically the polyvalent ASV. Now, it is available in two forms. One is the liquid and the lyophilized form. Remember, in a liquid form, one vial has basically 10 ml of ASV. That is a liquid form. In a lyophilized form, it would be in the powder form. So what you have to do is you have to take 10 ml of the distilled water and reconstitute it and give it in the lyophilized form. In a lyophilized form, liquid form, it has to be stored at a temperature of around 2 to 8 degrees Celsius. Whereas in a lyophilized form, it can be kept. Early administration, as early as possible, is the treatment of choice for ASV. When the patient comes, look at the systemic signs, neurological, hematological signs, look at the whole blood clotting time. If there are features of envenomation, start off with ASV. Now, any of the features of systemic envenomation, which I have said before, platelet count of less than 1 lakh, a non-coagulable blood in 20 minutes, that is a positive whole blood clotting time at 20 minutes, spontaneous systemic bleeding anywhere in the body, neurotoxic signs such as any ptosis, ophthalmoplegia, dysphagia, or paralysis, indication for ASV. Any cardiovascular abnormality such as any arrhythmia, atrioventricular node blockage, or any shock, again suggests need for ASV. Persistent and severe vomiting or abdominal pain is also one indication that has to be kept in mind. Remember, do not empirically start. Have a high degree of suspicion. If you feel that it is a snake bite, you can give ASV, but otherwise mere abdominal pain is not an indication. You have to correlate it with the other findings. Now, what is the mechanism or the basis of which we give 10 vials of ASV? We say that we give 10 vials of ASV or 6 vials of ASV. Why? Remember, each ml of a polyvalent ASV neutralizes 0.6 mg of the Indian cobra venom. Now, if you have seen my earlier slide, you would have realized that the average bite, the venom that is injected into the blood, is around 60 mg for an Indian cobra and 63 mg for a Russell's viper. Now, when you're saying each ml of an ASV, it means that it neutralizes 0.6 mg. One vial of ASV has 10 ml. So 10 ml means one vial can neutralize 6 mg of Indian cobra or 6 mg of Russell's viper. So this is why we give 10 vials. So 10 vials can neutralize 60 mg. So that is the basis why we give 10 vials usually as a starting dose for anyone who presents with a snake bite. So 10 vials of ASV in 250 or 500 ml of NS or 5D, which is given slowly over half an hour to 1 hour. So this is the reason why we give 10 ASV. This is the same thing that I've pointed out here, neutralizing capacity of 10 vials. So 60 mg and 60 mg here for both Cobra and the Russell's Viper. Now, do we require a test dose in case of ASV? The answer is no. In the last 3 to 4 years, they have actually studied that it has no predictive value in detecting unexpected or late serum reactions, and therefore a test dose should not be done. Rather, they have found out that giving a test dose may actually pre-sensitize the patient and give a greater risk. So do not give a test dose. Now, what is the dose for ASV for a hematotoxic and a neurotoxic? For a hematotoxic, we give 10 vials for a Russell's Viper, and which is usually given slowly over half an hour, followed by 2 vials every 6 hours as infusion in 100 ml of normal saline till the clotting time normalizes. This is the low dose infusion therapy. The one which many of us follow is the high dose intermittent bolus therapy, where you give 10 vials of a polyvalent ASV given over half an hour, followed by 6 vials 6 hourly as a bolus therapy. Now, in what do we follow in St. John's? In St. John's, what we follow is actually we give 10 vials of ASV in 250 or 500 ml NS given over 1 hour. And after that 1 hour, we repeat in a vasculotoxic snake bite. After 6 hours, we repeat a PTINR and an APTT. If it is still deranged, we give another 10 vials of ASV. The maximum dose that we give in case of a hematotoxic is up to 25 vials of ASV. Whereas in a neurotoxic, the maximum that we give is actually 20 vials. Now, what is the WHO criteria say? It gives 10 vials stat as infusion over half an hour, and a second dose of 10 vials after 1 hour if no improvement within the first hour. In our protocol, we give usually after 1 to 2 hours, we'll see if there is any improvement in his ventilatory status or any neurotoxic status. If there is still symptoms of neuroparalysis, we will give a second dose. So remember, ASV for a hematotoxic snake bite, the maximum dose that we give is 25 vials. And for a neurotoxic, the maximum is 20 vials. The first one that we follow, it has written 10 vials, which is given every 6 hourly to a maximum of around 25. In the other one, you can give 10 vials stat followed by a second dose after 1 hour. What about the ASV dose in pregnancy? It is treated exactly the same way as in case of the adult population. Now, for the impact of the fetus and for the fetal assessment, you will call a gynecologist the meantime. In the children, remember the ASV dose is the same. The only difference is that it is diluted in 5 to 10 ml per kg of the body weight of normal saline. Now, what about in those who require life-saving surgery? In such conditions, especially with an intracranial bleed or a severe necrotic pancreatitis with intra-abdominal bleed, a higher dose of ASV up to 30 vials can be administered. Again, the level of evidence is actually a moderate level of evidence. They haven't studied so much, but they have suggested that it is beneficial to give ASV every 6th hourly up to a maximum of 30 vials. And victims who arrive late. Now, especially in the first case scenario, if you have seen the child, we started to give ASV 24 hours after the history of the initial bite. So from that history, you can realize that you can give ASV anytime. Remember, the efficacy of ASV is best, especially when given early. According to the studies, they have found out that the ASV is best when it is given within 4 hours of a snake bite, but it can be given up to 5 to 7 days post history of a bite, especially in a hematotoxic snake bite. Local envenomation, again, many of these patients would have features of local envenomation. And when we are saying the rapid ascent, this is the same thing that I have pointed. If it involves more than half of the bitten limb, rapid extension of the swelling, bites onto the digits, and an enlarged tender lymph node. Always mark the area on the lymph where the swelling is there. You have to serially monitor. This is the same thing that I mentioned. Remember, we usually administer it in a 250 to 500 ml of normal saline or a 5% dextrose. Now, we will come to another area which is called, in a neurotoxic snake bite, what is the role of giving neostigmine and atropine? Remember, when I told before, a neurotoxic snake bite, the neurotoxicity usually affects at the level of presynaptic neurons and the postsynaptic neurons. What we want is there is an increased breakdown of acetylcholine, and we want the acetylcholine actually to be there. So in order to prevent the anticholinesterase, we give neostigmine. This is a recommendation which is given in WHO, and the dose of neostigmine is 1.5 to 2 mg IM. And if neurological improvement occurs, it should be continued every half hourly till the symptoms resolve. Remember, neostigmine test and the hydrophonium test, along with the atropine, is not found to be beneficial if it is a presynaptic neurotoxicity. Now, response to ASV, you will continue ASV till there is normalization of his vitals. It's basically normalization of his BP until the bleeding completely stops. 15 to 30 minutes is the usual time. Normalization of the coagulation parameters within 6 hours. So remember, any patient whom you start ASV, do not forget to repeat a PT, INR and an APTT after 6 hours, especially in a hematotoxic one. And neurological sign which will be resolving within 30 to 48 hours. So if you can see there, it takes a long time for the neurological symptoms to actually get resolved. So in a neurological snake bite, remember that just ASV administration is not enough. The patient might actually go into ventilator failure. So therefore, a referral to a higher center with the need of SOS ventilatory support, intubation and further care should be clearly explained to the patient. So this is the summarizing the history of the protocol that we do in an emergency. History of snake bite, always follow the ABCD: airway, breathing, circulation, and disability. If there are signs and symptoms of envenomation, if it is yes, do a 20 blood clotting time, the other coagulation tests, consider give anti-snake venom, refer to the adequate center for adequate monitoring, requires mostly ICU. If there are no symptoms, repeat a 20-minute whole blood clotting time. Remember, even if the whole blood clotting time initially is negative, remember to repeat it serially after another 1 to 2 hours, because the changes can be delayed even up to 6 to 8 hours. Now, what are the complications of a snake bite? The most common complication of a snake bite is a compartment syndrome, for which the treatment is going to be fasciotomy. Second one is renal failure, especially in hematotoxic, where it can lead to acute tubular necrosis, and those who have gone into frank renal failure would require dialysis. The other ones include DIC and vasculitis. The other complications include, third one is shock. Again, it's a kind of a distributive shock. Treatment is going to be, number one, IV fluids in order to fill your intravascular volume. Blood products if there is especially increased blood loss and severe thrombocytopenia. Cardiogenic shock, you can give dobutamine only if the BP is more than 80 systolic. Neurogenic shock, noradrenaline or dopamine. In rural setting, give IV fluids, and if you have noradrenaline, you can start at a dose of around 1 to 5 micrograms per minute. Shock lung, you can give where there will be respiratory distress and hypoxemia. It is O2 support, that is ventilation support and adequate oxygenation. And bleeding is by means of correction of coagulation factors by means of administration of FFP and platelets. Now, what are the various reactions you can have after giving to ASV? There is something so-called as early reaction to a delayed reaction. Now, when there is a reaction to ASV, remember, stop the ASV. We do not withhold ASV. Stop the ASV. You can give epinephrine IM of around 0.01 mg per kg for a child, or 0.5 mg IM if the patient has developed into an anaphylactic reaction, 0.5 mg IM of 1:1000, adequate airway management, breathing, and circulation. Now, once these three are stabilized, where you are giving adequate IV fluids, pressors, you have maintained the airway and breathing, and after giving antihistamines, which is basically chlorpheniramine maleate of 10 mg and hydrocortisone, under strict monitoring, the ASV should be continued. Remember, earlier it was said that if you have an allergic reaction to ASV, that it may be completely stopped. Do not completely stop the ASV. You stop it only to stabilize this ABC, after which you should continue ASV with strict monitoring. The other reactions include a pyrogenic reaction, where the treatment would be giving paracetamol and giving him adequate cooling. The other one would be a late serum sickness reaction, which usually is quite delayed, more than 24 hours since presentation, where the treatment would be giving steroids, prednisolone of 5 mg Q 6 hourly. Now, this is the thing that I've told you a little before about the need for neostigmine and heterophonium. In many of the states in India, they do not actually give this thing because number one, due to the lack of neostigmine and hydrophonium, but otherwise, according to the WHO guidelines, this can be actually tried. Remember, neostigmine and hydrophonium, they are found to be more effective in neurotoxic snakebite as usual, especially in a post-synaptic symptoms. In a pre-synaptic symptoms, this is found to be less efficacious. This is the summary of all the symptoms that we have, the coagulopathy, the neuromuscular symptoms, and the local reactions of a snake bite and how we approach with it. Now, what are the differential diagnoses that we must have in mind when considering a snake bite? It could be various other things such as botulism, Guillain-Barré syndrome, any other kinds of paralysis. Rhabdomyolysis is something to be kept in mind, especially a muscle compression, crush syndrome, or a severe exercise in itself, which can cause an exertional kind of a rhabdomyolysis. Remember, rhabdo, which is usually associated with a snake bite, is usually painful and associated with local swelling, and therefore it can be differentiated from other causes. And remember to consider the other causes of coagulopathy, such as sepsis, trauma, and malignancy. Now, just a question: can any of you name what are the fab for snakes? What do they they can you can all can unmute, and if you can say loudly, what are the fabulous for snakes in our Indian setting?
They won't be able to unmute, but they can type it in the chat if you want.
Yeah, if they can chat, yeah. What are the fab for, if any?
Fab 4 snakes, is it?
Yes, fab 4 snakes.
Okay, you can put it in the chat for those who remember the Fab 4 snakes.
Okay, I think if I'll continue with this thing, I don't think there's. So it is basically the common crate, Naja Naja, that is the Indian cobra, the Russell's viper, and the saw-scaled fiber. This is called as the Fab 4. Now, another question for you. These are the less common poisonous snakes in India. The first one, identify the snake. Easy question. Can any of you identify the first one?
You can.
I think
Somebody's written cobra. Many have written cobra.
Yeah, so this is king cobra. It's not the Indian normal cobra. It's the king cobra, which is Ophiophagus anna. The second one is quite common in Kerala, and it is a green colored snake. It's quite poisonous. Can anyone name it? This is actually the Malabar pit viper. The treatment is the same. The treatment is the same as that of any other snake per se. Now, what are the other adjunctive therapies that we give other than giving ASV? First one, clean and disinfect the area of the bite. Second one, limb elevation for the swelling. And if there is development of a compartment syndrome, fasciotomy is the treatment. Second one is neurotoxicity. As I said, there are two types, presynaptic and postsynaptic. In postsynaptic, anticholinesterase are found to be helpful, especially found with cobra snake. In a presynaptic state, the management is usually ventilatory support. Anticholinesterase are not found to be that helpful. Coagulopathy, life-threatening hemorrhage and all, especially when the platelets are less than 1 lakh, you may give platelets and FFPs. Though the studies have shown that they do not improve the outcome, WHO guidelines say that you can actually give it if there is frank bleeding episodes. Fourth one is rhabdomyolysis, where the treatment is going to be adequate fluid resuscitation with in adults 200 to 300 ml per hour and children 4 ml per kg per hour. Remember, in this fluid administration, fluid resuscitation, your end product is maintaining an adequate urine output. In a snake bite, especially when you're considering AKI, your urine output should be greater than 1 ml per kg per hour. So that is your end goal. End goal while doing this thing should urine output of greater than 1 ml per kg per hour. In case of renal failure, the treatment is going to be dialysis and treatment of the underlying cause. Urine output, as I mentioned, do not remember as 90 ml. It is greater than 1 ml per kg per hour. And now the next one is cobra spit ophthalmia. What happens is sometimes the cobra spits the venom, and the venom, when it falls onto the eye, can cause ophthalmia. The treatment for this is going to be topical antibiotic treatment. Why? The venom of the snake is quite notorious to having certain anaerobic bacteria, which is highly notorious to cause corneal ulcers. Therefore, topical antibiotic treatment with proper eye irrigation is the treatment for an ophthalmia. And last would be the tetanus prophylaxis. Now, tetanus prophylaxis, as we do it for any other patients, remember, if the patient has received 3 previous doses of tetanus toxoid immunization, and if not received in the last 5 years, then you would give a TT. Immunoglobulin is not required in such circumstances. If it is a dirty wound, or if it is a grossly contaminated kind of a wound, remember to always give human tetanus immunoglobulin, especially if the patient has been properly vaccinated. If the patient is not vaccinated, remember to give tetanus immunoglobulin. I hope you're clear. So if it is a dirty wound, and if more than 3 doses, that means proper tetanus toxoid vaccination has been given, remember that you will only give a booster vaccination only if the last dose was more than 5 years. No need for immunoglobulin. If you have been immunized in childhood, but your last dose of tetanus toxoid was more than 5 years, you will give a booster tetanus toxoid and an immunoglobulin in case of a dirty wound or a contaminated wound. Now, another concept is forced alkaline diuresis. It is quite controversial, and according to the Ministry of Health, they have not recommended this treatment. What they do is here, in order to prevent the risk of AKI and the need for dialysis, they have said to give a trial of forced alkaline diuresis in order to avoid nephropathy. The treatment here, what they have recommended is injection furosemide, NS, and ringer lactate with mannitol. Remember, this is just that has been given in the guidelines according to the API, but it has not been sanctioned, and it is still controversial, and it has not been recommended according to the Ministry of Health and Family Welfare. So these were the references for the study. If any doubts, please do ask. Thank you.
Thank you very much, Dr. Jobin. That was very interesting topic, and I myself learned a couple of things. We have one question for you that is from Dr. Sister Leas.
Yes.
Her question is, we do come across a green snake bite with very bad cellulitis. Do we need to give ASV or only manage the cellulitis?
No. That is the one which usually the green snake that they have told is basically the Malabar pit viper. That is the green snake. And another viper is there called as the bamboo pit viper. For both of which we have to give ASV because it acts more like a viper itself. So it acts more of a hematotoxic snake bite, and therefore we have to give a ASV.
Okay, thank you very much. Now, next we have Dr. Chaitanya, who will be giving his talk on the management of MIs. Dr. Chaitanya?
Congratulations, Dr. Jobin. I think that was an excellent talk. As Chaitanya gets ready, I just want to say that to you.
Yeah, thank you, ma'am.
Very well done. And we look forward to Chaitanya.
Good evening, everybody. Am I audible?
Yes.
Thank you. I hope my slides are visible.
Yes, go ahead. Yeah.
Yes, thank you, ma'am. Good evening to everybody. At the outset, I'd like to thank
Chaitanya, I'm just going to interrupt you.
giving me this
Chaitanya, I'm just
opportunity
going to interrupt you.
At this rural outreach webinar. Topic which is quite commonly encountered. People, sure, ma'am. Sure, ma'am.
No, your voice is kind of waning and waxing, so you might want to put off your video once you start speaking so that you can get your audio clear. Okay, sorry. Please go ahead. Yeah.
Sure, ma'am. Will do. Thank you. Yeah, will do. Is it better now, ma'am?
Yes. Yeah. Fine. So you can share your screen, but just put your own video off. The screen's gone off. Yeah.
Okay. Is this better, ma'am?
Much better. Thank you.
Thank you so much. The topic of diagnosis, management, and updates in acute myocardial infarction is something that's very, very important because over the years that I worked in St. John's, I found a lot of doctors working at the rural bond centers as well, sending a lot of ECGs and queries in. And acute MI is something that if you don't act, time is equal to myocardium. Hence the picture of the clock with the heart, because time is equal to myocardial tissue. And the longer you take to diagnose and the longer you take to refer a patient who has an acute myocardial infarction, the more chance of damage to the heart muscle and thereby the higher chances of both morbidity and mortality. So this is the outline for today's session. I'll be discussing a few definitions of myocardial infarction. The reason I'm defining a few topics that are required to be used when you talk about acute coronary syndromes and MI. I'll talk about the diagnosis of acute coronary syndromes based on symptomatology, investigations. The outline of management algorithms, I won't stress on this too much because I want to stress on point number 4, which is how are you going to manage an acute MI at a rural bond center? A few case vignettes at the end, and finally a take-home message. So what are the definitions that you need to know, or what are the must-know definitions when you talk about myocardial infarction or acute coronary syndromes? Stable ischemic heart disease is probably the most common thing that you will see, especially in an OPD follow-up. It may not come to your emergency, but they will come to you in an OPD follow-up, which is your stable ischemic heart disease, which is caused by atherosclerosis of the coronary vessels and gradual narrowing, which leads to the manifestations of stable angina. It's very important for everyone to know what stable angina is. These are recurrent ischemic episodes, which are precipitated by a particular trigger, causing an increase in the oxygen demand more than the ability for the myocardium to get its blood supply, classically relieved by resting. So a patient who comes to you either to your OPD or the emergency with angina, it is extremely important to identify whether this is his pre-existing angina which has come again, or if it's new onset angina. If the patient is a known case of coronary artery disease, come with a particular episode of angina, which is precipitated by a particular trigger relieved by rest on nitrates, it's a stable angina which doesn't require much worry on part of the both patient and doctor. You may need to titrate his nitrates and send him home. But if a patient comes to you with a new onset angina, or he says, I've had angina for the last 2 years, it's getting worse from this morning, I've had to take more nitrate tablets than I normally do, and it's getting precipitated even at rest. These are red flag signs in angina, which bring me to my next slide, which is acute coronary syndromes. Not every acute coronary syndrome is MI. Please remember there are 3 types of acute coronary syndromes as per the European Society of Cardiology and the American Cardiology Council. Unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. Unstable angina and non-ST elevation myocardial infarction often follow something called the non-ST elevation spectrum, where both form the same disease. Unstable angina is probably a precursor. As the name suggests, non-ST elevation myocardial infarction is diagnosed with an ECG where the classical ST changes. The ST elevation is not seen. In fact, you see ST depressions or T wave inversions, and those are called non-ST elevation MI. And then you have your classical STEMI, which causes anxiety for both you as well as the patient. Typically, when there is a partial obstruction by the intracoronary thrombus, that can lead to myocardial ischemia without ST elevation. This is because the thrombus is partially occlusive. And because it is partially occlusive, some amount of blood is still able to pass through to the underlying myocardium. If the patient has a partial occlusion and there is evidence of ST depressions or T wave inversions with classical chest pain, but the troponin I and T, which are the markers we use for myocardial injury, which I'll come to later, are negative, we call it unstable angina. If a patient with unstable angina is found to have troponin I elevation, it then becomes non-ST elevation MI. So as you can see, it's a simple differentiation between the two. If you have patients with angina, ST depressions or T wave inversions with negative tropi, it is unstable angina. Typical myocardial ischemia anginal symptoms, ST depressions, T wave inversions with positive tropi, it becomes NSTEMI. It's not often that you need to differentiate the two, but it's very important because if you see an ECG and you find a negative tropi, please do not label them as no acute coronary syndrome. Unstable angina will always have a negative troponin I and troponin T. And this is very important. And this is something I want to stress upon everybody who's listening in, that please don't assume that if you see T wave inversions and ST depressions with a negative tropi, you still don't say, okay, fine, these are non-specific changes, there's nothing need to be done. No, this is still a patient who has an acute coronary syndrome. You label them unstable angina. The treatment, in fact, remains the exact same. Whereas if the coronary thrombus is complete and acute and occludes the whole epicardial coronary artery, it causes ischemia to the transmural, that is the whole myocardium. And that causes the classical ST elevation MI, which we are all familiar with. Now, why did I go into these definitions when we are talking about how to manage MI? It's important that you are able to, in your head, define and discriminate a patient who has stable angina, who may not need acute care, unstable angina and NSTEMI, the patients require acute care, and STEMI, because as I mentioned, and I will keep mentioning that again and again, time is myocardium. The longer you waste in diagnosis, the longer you waste in initiating treatment, and the longer you waste in the referral to a cardiac or a higher center, the higher the chances of mortality and morbidity, including sudden cardiac death. So I will be stressing upon this repeatedly, that time is equal to myocardium. If you look at the flow chart or the picture that I've put up on your screen, this is a very simple diagram which links whatever I've just put up in the 4 slides. If you take a patient who has stable angina, which is the first picture that I've put up, there is an atheromatous plaque which is causing a mild narrowing. The patient develops only demand ischemia. That is when he exercises, when he has any emotional upheaval, or when he has a hot shower or a cold shower, or any sort of physical exertion, he might come to you with stable angina. Now, why did I say stable angina? I'm not going to do much because both the ECG and the troponin I will be negative in stable angina. And so these are patients who just need a titration of their nitrates or possibly their beta blockers. 2, 3, and 4 are key for all our rural doctors here. Unstable angina, the patient has an atheromatous plaque with or without a prior history of stable angina, which has undergone rupture or erosion, causing a stimulation of the coagulation cascade and forming a thrombus. Again, please remember there is supply ischemia. There is still some amount of blood flow going. It's a partial occlusion where you might see a normal ECG, you might see T wave inversions, or you might see ST depression. These are the 3 classical ECG findings of both unstable angina and NSTEMI. If you look at the diagrams between the two, you look at the ECGs between the two, it's almost the same, except in NSTEMI, the thrombus occlusion is slightly larger. But please remember, unstable angina can have a normal ECG, it can have T wave inversions or ST depression, as can NSTEMI. So then you will tell me, sir, patient comes to me with chest pain with a normal ECG and negative tropi. Why would I suspect unstable angina? History taking in 2020 is still key. It may not be as relevant with all the investigations and the whole battery of tests that we do, but taking history of a classical angina, despite a normal ECG and normal tropi, still hold good even in this day and age. So if you see a normal ECG, please repeat ECG after 30 minutes to look for any dynamic changes. You compare this to a STEMI where there is complete occlusion of the blood vessel. You see the classical ST elevation, T wave, hyperacute T wave, and ST elevation, which is very difficult to miss. Again, here tropi is elevated. So NSTMI and STMI have elevated tropi because tropi is an indicator of myocardial injury. And the positive biomarkers tell you that you're dealing with a myocardial infarction. How do you diagnose an acute coronary syndrome? Now, this is extremely um, key to know that to diagnose an acute CS or an ACS requires three things. One, symptomatology. Please do not neglect symptomatology, right? That's the most important thing, because that tells you or guides you into which way you want to do your further investigations. So, to symptomatology of angina pectoris, as we all know, it has 7 different points that you need to ask. The character, which can be squeezing, crushing, burning, or a chest heaviness. Substernal location, relating to both shoulders or the inner aspect of the left arm classically, even the jaw and the upper back. I've had patients who come to me with toothache from the dentist who've been diagnosed with acute MI. Generally ask for 2 to 5 minutes. This is important. If the patient comes to you and says, "Sirs, my angina has always been less than 5 minutes, but today it's been for the last 30 minutes. Any anginal chest pain lasting for more than 20 minutes, irrespective whether they've taken nitrates or not, is acute myocardial infarction." Aggravating factors can be exertion, anxiety, emotion, relieved by rest or nitrates, and associated with any of the 3 symptoms: syncope, dyspnea with palpitations, or extreme sweating, that is diaphoresis. Now, how many patients will you see with a classic angina pectoris? Only 40 to 50%. Only half the population with an acute coronary syndrome might come to you with classical anginal chest pain, presented to you with this sign, which is classically Levine's sign, right? This is Levine's sign, described as holding a fist over your sternum, where this is the description of the squeezing or heavy chest pain. The remaining 50% of patients may come to you with what we call angina equivalents, nausea and vomiting. This is something we commonly see in younger individuals, especially with an inferior wall myocardial infarction because of excessive vagal stimulation. And often people have been treated as acute gastroenteritis, whereas they've had inferior wall MI. Extreme sweating, dyspnea with palpitations, or atypical presentations as syncope, an acute abdomen, right? Sometimes inferior wall MI might present with an acute abdomen, which is misdiagnosed as acute peptic ulcer disease or acute pancreatitis. When an ECG is done, or when the patient has unfortunately shock, we diagnose them as inferior wall MI. And sometimes in unexplained fatigue. So in what population will you look for anginal equivalents? Women, diabetics, and people above the age of 60 may not come to you with classical angina pectoris. So to keep a broader mind, symptomatology, which is atypical, might also add to your diagnosis. Always ask for a past history of angina. Patient comes to you with acute angina, you immediately think, oh, he's having a heart attack. Whereas he tells you, no, I've had angina for the last 2 years. This is just my regular attack. You need to ask a few questions to ensure that it is stable and not unstable angina. Obviously, a previous heart disease, diabetes, hypertension, dyslipidemia, or chronic kidney disease are all risk factors for an acute myocardial infarction. Always ask if patients are on antiplatelets and anticoagulants. Please remember, if you've had an acute MI and you're on antiplatelets, it doesn't mean you will not have another MI. In fact, as per the universal definition of myocardial infarction, that is the 4th edition, which came out a couple of years ago, there are 5 different types of MI. And type 4 and type 4 MI are patients who've developed MI despite having had a stent put in or a CABG done. I didn't want to put that up because it's quite detailed. But please remember, just because they're on antiplatelets doesn't mean they cannot have another myocardial infarction. Is examination important before an ECG? Yes. You start telling the sister to get the ECG machine, whereas you examine while she's bringing it. 1, pulse. Obviously, you keep your fingers on the pulse. Bradycardia is a dangerous sign in MI. If you see a bradycardia, it could be an inferior wall myocardial infarction due to AV nodal dysfunction. You might have extreme bradycardia. Again, there's vagal stimulation here. Atrial fibrillation, ventricular arrhythmias, and premature complexes are the common arrhythmias that you can see in a patient with MI. In fact, acute atrial fibrillation is known to be seen in patients who have an underlying acute myocardial infarction. It might be difficult to diagnose because of the irregular ECG changes that you see. Examination of BP is again very important. Some patients might come to you, especially with extensive anterior wall MI, may come to you with acute decompensated left ventricular failure with flash pulmonary edema. And they may come to you with high blood pressures requiring diuretics. Whereas some patients, especially who have an inferior wall MI, can come to you with hypotension or even cardiogenic shock. This is commonly because they develop a right ventricular MI. And the inferior wall of the heart can also extend to involve the right ventricle. And when there is a right ventricular myocardial infarction, the preload reduces. So both hyper and hypotension are something that you have to watch out for. Look for the JVP, because an elevation of JVP shows right heart failure, which can tell you that there's an RVMI. Check the oxygen saturation, which will be reduced when there's pulmonary edema due to LVF. Auscultation in acute MI might reveal an MR murmur or LV S3, S4. This doesn't add any prognostic value to you, but it's just important that you do auscultate. And of course, bibasal crackles or rails tell you that there is pulmonary edema, and these are patients who will crash fast. The third and most important diagnosis of ACS. No ACS can be diagnosed without an ECG. The European Society of Cardiology says if you have not done an electrocardiogram within 10 minutes of a patient with a suspected ACS walking into your casualty, you can be held responsible. So it's very important that an ECG is done within the first 10 minutes of evaluation. In stable angina, as I mentioned, there is usually normal unless of course you see some transient ST depressions during any episode of stress. Please do not let the patient leave without a repeat ECG. Always repeat an ECG after 30 minutes to make sure that their changes are documented. Because often in the early phases of a patient going from stable angina to myocardial infarction, there may be a period where the ECG may be normal. Now, how do you diagnose unstable angina and NSTEMI? I will show you a bunch of ECGs to diagnose. Horizontal or downsloping ST depression. We are talking about non-ST elevation MI. Non-ST elevation, in other words, means ST depression, right? Why didn't we call this ST depression MI? Doctors are famous for making life more complicated for themselves as always. So we call it non-ST elevation MI. So any ST depression of more than half a millimeter, that is half a small box, in two contiguous leads. Contiguous means leads which are in close anatomical relation to each other, like B5, B6, 2, 3 AVF. More than 1 mm or more than 3 mm are very bad prognostic factors for them. So ST depression is classically seen in unstable angina and NSTEMI. T-wave inversions of at least 1 mm deep, and again, two contiguous leads or two continuous leads, which are dynamic. You've had an ECG this morning at 8 a.m., which is normal. A 12 p.m. ECG shows T-wave inversions, new onset. We call these dynamic changes. And these are the two important changes you look for in an MI. The types of ST depression. There are 3 types of ST depression. You have an upsloping ST depression, a downsloping ST depression, and a horizontal. Upsloping is not very specific, but downsloping ST depression and horizontal are found to have high mortality predictability. Now, I'm sure this ECG is visible to all of you. If you look at this ECG, you can see diffuse ST depressions in 1, 2, AVF, and V5, V4, V5, V6. Even in V2, V3, if you look at, there are subtle ST depression. Always look at the baseline, and then you can see the depressions. They fit the criteria for diffuse ST depressions. And if you look at it, the T waves are also inverted. So this is a classical NST elevation, non-ST elevation MI. Now you might ask me, sir, this is involving 1, 2, AVF, V4 to V6, V2, V3 as well. It doesn't stick to certain arterial territories like an STMI. Please remember, NST elevation MI need not stick to arterial territories like a STEMI. You don't expect it to stick. It can be a diffuse change because this is a subendocardial injury. This is also NSTMI or unstable angina. T-wave inversions in 1, AVL, and V5, V6, right? This is also, if I saw this ECG, right, and there were new onset T-wave inversions, I would call this unstable angina if the tropi was negative and NST elevation MI if the tropi was positive. So you can get either ST depressions or T-wave inversions or both or none. All 4 are possible. So when you put in your ECG, you put in your clinical examination and your history, only then can you be sure that you're dealing with an ACS. Now, STEMI, of course, is classical. It's very difficult to miss a STEMI unless they come to you in the hyperacute phase. What is the ECG definition of STEMI? Persistence of ECG features more than 20 minutes of ST elevation of at least 2.5 millimeters in V2, V3 if the patient is less than 40. If they're more than 40, 2 mm is enough. 1.5 in women, or any ST elevation of 1 mm in other leads sticking to an arterial territory. right? So please remember V2 and V3, you require at least 1.5 in women, 2.5 or 2 depending on the age of the man. But in other leads, V4, V5, sorry, V5, V6, 1, 2 AVF, even a 1 mm ST elevation, provided it fits the criteria, is ST elevation MI. Another thing that I commonly get a referral for is a left bundle branch block. A new onset left bundle branch block should be considered as an acute MI unless you have a previous ECG showing the same thing. A left bundle branch block will develop when there is an anterior wall MI involving the left anterior descending artery supplying the bundles that supply the left ventricle. This is an ECG showing multiple colors corresponding to arterial territories, which I commented upon when I was talking about ECG. One AVL, V5 and V6 correspond to the lateral wall of the heart or the lateral part of the ventricle, which is mainly the left ventricle. And this is supplied by the LCX. LCX stands for left circumflex artery, right? The green is the V1, V2, V3, V4. This is the anterior and anteroseptal leads. V1, V2 consists of septal leads, which are the interventricular septum, and V3, V4 is the anterior leads, and these are supplied by the left anterior descending. The remaining, which is in red, is 2, 3 AVF, which is the inferior wall corresponding to the right coronary artery. And when you see an inferior wall MI, you must always also check that the right ventricle is not involved in case of a right ventricular wall MI. Why is it important to know the arterial territories? Because this is a predictor for mortality as well. If you have an extensive anterior wall MI, the mortality risk is almost 30 to 40% compared to a lateral wall MI, which is only 15 to 20%. Are there phases in an acute MI ECG? Absolutely. This is why I said never write off a patient who's come to you with angina with a single ECG. It has to be serial ECGs. In the first 10 to 15 minutes of an acute MI, the ECG may be normal. This is only ST elevation MI, mind you. After the first 30 minutes, you can see a hyperacute or a tall, peaked, symmetrical T wave. And picking this up is very important. Only if you've seen more ECGs will you be able to pick this up. Then, of course, it progresses to the classical ST elevation, which is where most of us will pick up the MI. In hours today's, the ST segment will start to come down and the QRS complexes loses the height of the R wave as the ventricle wall becomes infarcted, ultimately leading to the formation of a Q wave, and then the T wave inversion always follows. And ultimately, the only residual might be a Q wave with an upright T wave. So you might see ECGs in this sector, right? So please don't miss this. Picking up an ECG here in this phase takes a lot of experience, but if you can, you will save the patient's life. A couple of sample ECGs before we go into the diagnostic algorithm. This is an ECG showing classical ST elevation of more than 2 mm in V1, V2, and to some extent in V3. This is an antero or a septal myocardial infarction. Acute ST elevation, septal myocardial infarction. ECG number 2. This is something that all of us would have seen, whether you are seen it actually or you watched any television show, you will know that this is the classical ECG that they show. This is an ST elevation. If you look at it in AVL, lead 1, V2, V3, V4, V5, and V6. And this, if you look at it, it looks like a tombstone. This is called the tombstone ST elevation when there is an occlusion of the left main coronary artery. And this is a classical extensive anterior wall MI because it's involving V1 to V6 as well as AVL and 1. The whole left coronary artery is involved. These patients have a mortality of up to 50% if not picked up early. This is an ECG showing ST elevation. If you look at it carefully, V4, V5, to some extent in V6, but classical ST elevation in 1 and AVL. So if you put together 1 AVL, V5, V6, this is a lateral myocardial infarction, probably the left circumflex artery. Now, prima facie, if you look at this, you would say, oh, I'm glad I got to know this is a lateral wall MI. I'm very happy I know which artery. But if you look very carefully, you will notice some ST depressions in lead 3 and AVF. These ST depressions are reciprocal changes in the inferior wall. And this tells me that the left circumflex artery is also supplying the inferior wall of the heart. 30% of the population can have a left circumflex supplying the inferior wall of the heart. These are patients who in a lateral wall MI can develop an inferior wall ischemia and hypotension. So picking this up in this ECG is important. But if you picked up the ST elevation, I am more than happy. Of course, a classic inferior wall MI, ST elevation in 2, 3, and AVF, which are the inferior leads, some reciprocal changes in 1 and V1, V2, which could indicate a posterior wall MI. Don't worry about it. If you've picked up inferior wall MI and you've checked the blood pressure, because I mentioned bradycardia and hypotension can occur in inferior wall MI due to right ventricle involvement. If you look at this and you pick up the inferior wall MI, I am more than happy. Now, this is the most complicated ECG of today. I promised you that. This is a classical left bundle branch block, right? It looks like somebody scribbled on the ECG paper, but this is a classical left bundle branch block. Now, when you see an LBBB, I've already mentioned to you, an acute left bundle branch block is MI unless proven otherwise. But supposing the patient has a previous ECG of 3 years ago showing a left bundle branch block, this is also left bundle branch block. Can he still be having a heart attack? Absolutely correct. This is called Scarbosa's criteria or modified Scarbosa's criteria. I'm not going to go into the details. I'm just showing you. If you see a left bundle branch block with a significant ST elevation of 1 mm, right, in any lead or more than 5 mm in a lead where the ST elevation is in opposite direction of the QRS, then you can call it an MI. In these cases, the only thing that you will do when you see an LBBB is to call me immediately and send me both ECGs. Cardiac biomarkers, I have not stressed upon this because a few centers may have it, a few centers may not have it. The most sensitive we use are troponin I and troponin T. If you have CKMB, that's also used. Why do we do cardiac markers? To differentiate unstable angina from NSTEMI. Unstable angina, cardiac markers negative, NSTEMI, cardiac markers positive. This is just a compilation to show you that in a patient who has no minimal symptoms, normal ECG, negative tropi, you can discharge them and rule them out as non-cardiac. But a serial ECG showing ST depressions or ST elevations with a borderline tropi or a strongly positive tropi can be unstable angina, NSTEMI, or STEMI. And this is where if you add troponin, if you have it at your center, it adds value to your diagnosis. The other investigations in an acute setting, you're not going to be able to do. But one thing I implore all of you to check is the GRBS. 30% of patients with diabetic ketoacidosis can have an underlying ACS. And if the patient is going to be with you for a while, of course, lipid profile, creatinine, echo, and chest X-ray. But these are not mandatory in the diagnosis of an acute coronary syndrome. So now you've got your history, you've got your examination, and you've got your ECG showing an acute MI. Now, this is the fun part over. Diagnosis, you feel good about yourself. This is the fun part. That is done. Now it comes to the serious part, which is what are you going to do about it? This is the most simplified algorithm that I could find. There, of course, it has been updated, but I think this is the best algorithm that I could find for all of you to follow. You've got a patient who has an ischemia or an infarction. Monitor the ABCs as always, airway, breathing, circulation. Obtain a 12-lead ECG. You've done this 3 so far. You've diagnosed MI. Always check the vital signs every 10 minutes. It's must that as long as the patient is in your hospital, either you're going to admit them or refer them. If you've diagnosed an acute coronary syndrome, every 10 to 15 minutes, vitals, pulse, blood pressure, and saturation must be checked. And we give the immediate ED management, which is oxygen at 4 liters per minute if there is hypoxia, aspirin, 160 to 325 mg, nitroglycerin sublingual, and morphine IV. This is the classical mnemonic MONA. M for morphine, O for oxygen, N for nitrates, and A for aspirin, though the order is actually the other way around, ANOM. So aspirin, 160 to 325, we always give 325 mg. Sublingual nitroglycerin, I'll come to the doses later, and morphine with oxygen is the MONA. This is for both NSTEMI, unstable angina, as well as STEMI, all 3. Now you've got an ECG, which has told you either you're dealing with an acute ST elevation MI. If the time of onset is less than 12 hours, it is your job to refer them to a center which can do either thrombolysis, which is your door to needle time, or a PCI. PCI stands for percutaneous coronary intervention, nothing but an angioplasty. It is your duty to refer them if they come within 12 hours. If they've come outside the 12 hours, right, you can admit them and do the following protocol, whether it is the NSTEMI or the STEMI protocol. But if they're less than 12 hours, myocardium time is myocardium. You must refer them to a higher center. If they've come outside that period and you see that the T wave inversions, I mean, the T waves are inverted in an ST elevation MI, or the patient's symptoms have come down, a primary PCR may not be necessary. You will require an angioplasty eventually, but you have a little more time for you to stabilize the patient. So if the troponin is high, or the patient has any hemodynamic instability, signs of heart failure, these are all important referral indicators. Always start nitroglycerin, heparin, beta blockers, clopidogrel. This is just the list of the algorithm. What you're actually going to do, I'll come to separately. If you're going to admit them, of course, ASARB and statins. Now, some patients may have non-diagnostic changes with low risk. These are patients who should not be sent home. I told you, you need to do serial ECGs. If you don't have a chest pain unit, keep them in your emergency department. If you can do a tropi, do it. If not, repeat the ECG after 30 minutes or 1 hour. And if you find that the ECG changes are dynamic, that is, the ECG changes are showing, then you know you've had an acute coronary syndrome. But if the ECG changes remain the same, the patient's chest pain disappears with IV pantoprazole or any symptomatic treatment that you've given, consider them low risk ACS, send them home, but do tell them to come back for follow-up with your physician or cardiologist. This is the protocol that is followed across the world. Can you follow it in every rural bond center? I don't think so. So what can you do in the bond center? And this is where I think all of you should pay very, very keen attention. Vitals every 15 minutes. Patient should be in propped up position. Pulse BP SpO2 every 15 minutes is a must. You can lose a patient with myocardial infarction in a matter of seconds. A baseline ECG, which may be repeated if you have suspicious or inconclusive findings. Cardiac biomarkers if available. Once you are doing the ECG and you've diagnosed an acute coronary syndrome, instruct the sister to give the medications, which is in the next slide. I'll come to that. But simultaneously, always counsel the patients to arrange an ambulance and for referral to the nearest PCI center. Make sure all of you have information about the nearest referral center, which is able to do coronary intervention. But if they can't do angioplasty, at least they will thrombolyze the patient. Keeping this information with you is valuable. MONA, morphine, 2 to 4 milligram IV if there is no relief with a sublingual nitrate. Morphine reduces the pulmonary edema features. It reduces the patient's sympathetic overdrive. It reduces their pain. It's very useful in patients with ACS. In fact, improves the oxygen delivery. But if the patient is drowsy or hypotensive, please do not attempt morphine. If you don't have morphine, a common query is, can we give tramadol? Yes, it's not as effective, but the risk of seizures with tramadol is something that you have to keep in mind. Sometimes even simple IV paracetamol can also be used, but of course that is more of a Hail Mary than anything else. Some studies show that even if your saturation of oxygen is normal, please give supplemental oxygen at 2 to 4 liters. Some people believe that only the saturation is low, you should give it. I personally believe you should give them oxygen even at 2 liters, no harm. Nitrates, sublingual nitrates, 0.3 to 0.6 milligram kept below the tongue of the patient, repeat up to a maximum of 3 times. This will immediately reduce the preload and affect the heart. The sentence is, it will reduce the preload. Therefore, you will avoid if the patient has had hypotension, and you will avoid it if you're suspecting inferior wall MI. In patients who've had an inferior wall MI, I'm sorry I've not put that point up. If patient has had hypotension and an inferior wall MI, do not give nitrates. Otherwise, please give nitrates. They make a big difference. Loading dose of antiplatelets. Why are you giving antiplatelets? Are you going to dissolve the clot that has already formed? No. You are giving antiplatelets to prevent the platelets from adhering to the surface of the thrombus or plaque that is disrupted and preventing the clot from becoming larger. So you give aspirin 325, clopidogrel 300. Why have I written CHEW? Most of us in bond centers would have seen Ecosprin, right? That's the classical brand name. Dispirin, which is dispersible aspirin, is no longer available so easily. Ecosprin stands for enteric coated aspirin. If you swallow Ecosprin, it will take about 8 to 12 hours to kick in. So if you have a patient with Ecosprin, make him chew the tablet. Even plain aspirin 325, make them chew so that the aspirin enters the bloodstream as soon as possible from the stomach. A loading dose of atorvastatin is given not to reduce the cholesterol dramatically, but to stabilize the plaque and prevent thrombus propagation. Once you've done these 3 or these 4 steps, you will notice that within 10 to 15 minutes, the patient's symptoms will definitely come down. Are you going to give anticoagulants? If you're going to refer the patient and you're referring the patient to an institute which has PCI, you can, in a patient with unstable angina or NSTEMI, give IV or subcutaneous 5,000 units stat before they go. This is done so that if they have a longer ambulance journey, you are ensuring that some amount of anticoagulants have gone in to prevent the thrombus from propagating. But if they've had a recent GI bleed, any history of intracerebral hemorrhage, if they're using oral anticoagulants for some other reason, high blood pressure, any recent surgery, do not attempt to give heparin. This is not a standard guideline, but this is a guideline that is done in certain tertiary care, certain primary care setups. So this is how you manage unstable angina or NSTEMI. Early referral must be shifted in an ambulance with oxygen, with a doctor or nurse, and emergency drugs like adrenaline in case there is a cardiac event. So I will reiterate, MONA and anticoagulants are a must when you treat NSTEMI and vitals, ECG, and biomarkers. What if you're dealing with STEMI? Does the management change? Absolutely not. Again, vitals every 50 minutes, pulse, BP, and SpO2, a baseline ECG. Cardiac biomarkers are not so important in ST elevation MI, because if you see the MI, you know it's ST elevation, you don't really need cardiac markers. Again, a strict counseling to patients attenders so that they know that this is a heart attack. Morphine, oxygen, nitrates, antiplatelets. Again, exactly the same. Avoid nitrates if they have an inferior wall MI, patient has hypotension. Oxygen is a must. Morphine is a must. And again, the same loading dose. Again, chew the aspirin if it's Ecosprin. Aspirin 325, clopidogrel 300, Atorva 80. The numbers on your screen now, you should never forget as long as you practice to be a doctor. Not just in the rural setup, whenever you start practicing whatever field of medicine you take up, if you can remember MONA in ACS, you will save patients' lives, right? You get in the US, in the UK, you have small MI kits. And I think a few centers, even our Muglur center has an acute MI kit, which has these drugs. But in the UK and US, they often have these kits available, which are easily usable even by passers-by. So it's very important that you do not forget MONA. In STEMI, again, anticoagulants can also be given if there's a delay in referral. STEMI is something you should not take too much time with referring. If you have to keep the patient for whatever circumstances in, it is highly risky for you. Try to refer them as soon as possible. And IV fluids. Now you will say, sir, acute MI, IV fluids, he'll go into pulmonary edema. What are you saying? No. IV fluids in an inferior wall MI have known to reduce the risk of mortality, because in an inferior wall MI, if the right ventricle is infarcted, to maintain the preload and thereby the perfusion to the left side of the heart through the pulmonary circulation, you can give IV fluids, right? So this is the only condition in an acute coronary syndrome where you will actually say, I'm going to give IV fluids. Inotropes. If the patient is in cardiogenic shock, noradrenaline can be started as to maintain perfusion, especially if the patient is in transit to a higher center, you will have to start noradrenaline to start. Dobutamine is another option if available at your center. Now, if the patient has atrial fibrillation and underlying MI, do not give IV beta blockers or calcium channel blockers, because in an acute MI, they can cause AV blockade. Atropine if the heart rate is less than 40 in an inferior wall MI, and the only antiarrhythmic that you can use with safety is amiodarone, provided there is no hypotension. If the patient is in hypotension or cardiogenic shock, you cannot even give amiodarone. But if they have an AF for a ventricular tachycardia, which you've picked up with a normal blood pressure, you can give 150 or 300 milligram of loading dose of amiodarone, but refer this patient as soon as possible. Acute pulmonary edema, BP 160, 110 with rails and very breathless patient, furosemide 40 to 60 milligram IV can help you, but provided it is a left ventricular and anterior wall MI, not an inferior wall MI. VT and VF, if you detect it, follow the ACLS protocol. And if you're suspecting that DKA sugars more than 350 with acidosis, you can give 6 to 10 units IV actrapid in the transit for the patient to reach the other hospital. So at least you bring down the sugars so that the inflammation set off by the DKA is reduced. So this is how you will manage STEMI. Is there any difference? You will still do MONA. You will add anticoagulants if you can. IV fluids only in an RVMI. Inotropes in cardiogenic shock. Antiarrhythmics only amiodarone if you have a normal blood pressure. Atropine in case of bradycardia. Furosemide in case of pulmonary edema. VTVF, just follow ACLS. If you can remember these few drugs, handling an acute coronary syndrome at wherever you are will be extremely easy. Now, as we were speaking, Dr. Oliver actually brought up a very valid point, which is some patients might not be able to refer, you may not be able to refer them due to whatever, or inpatients under you in the ICU or in your ward develop an acute MI and are not willing to go anywhere. Can you treat them? Ideally, you have to be careful, but yes, you can. Do not thrombolize them without a physician, a cardiologist, or a CCU backup. Once you've given the loading dose, you have to continue antiplatelets every day, 150 milligram of aspirin, 75 clopidogrel, and 40 of atorva. Unfractionated heparin can be given as an infusion only if you have a lab which can do APTT every 6 hours. If not, just give 5,000 units IV or subcutaneous Q6H after ruling out the contraindications that we discussed earlier. Nitrates SOS, beta blockers, oral tablets like metoprolol, ACE or ARB once the patient is stabilized. Diuretics only in LVF with other supportive measures. These two slides are not to give you a false confidence that handling MI is easy. It's just that in case you are limited and you are not able to refer, or the patient really wants to stay there, or you have nothing else in your kitty, these are the things that you can follow. So this is with regards to inpatient care, or in case you're unable to refer a patient. I have 5 case vignettes, which I think will be very, very useful for everyone here. I want anybody who can put up on the chat screen what you think the ECG is showing and what you would do. I have a couple of questions after each ECG. ECG number 1 is the classical case scenario. A middle-aged male who's a known smoker comes with history of severe crushing left-sided chest pain for the last 2 hours. And when you see him, he's profusely sweating. He's got tachycardia at 122, which is regular. Blood pressure is 166 by 110 with 94% saturation on room air. The CVS is okay, but you notice that he has basal crackles when you auscultate the lungs. Okay. Is there anybody who will tell me what they would like to do first? You've got all the history, you've got the examination. Anybody on the chat box would like to tell me what they would like to do first in this condition? Anyone? Okay, I'll put up the ECG as well. I hope that's visible to everyone. This is the ECG in a patient, if the same patient, right? Got tachycardia. And if you look carefully at this ECG, you will see some findings. Again, is there anybody who wants to volunteer as to what you're seeing here?
Somebody's written LBBB.
Okay, so a left bundle branch block is closed, but an LBBB generally will have a wider QRS and have a W pattern in V6. Is there anything else that is striking? Focus on V4. Somebody can see what is striking in V4.
Elevation.
Yeah, so classically, this is an ST elevation, which is starting from V2, V3, V4, and V5. So this is a involvement of the septal part as well as the anterior part of the left ventricle. It's an anteroseptal myocardial infarction. So this is an acute ST elevation myocardial infarction involving the anteroseptal part. So what will you do? How will you manage? The management of acute coronary syndrome ST elevation MI, I've just told you. Wherever you are, you will follow MONA. Is there any contraindication to give morphine? No, the patient is absolutely conscious and fine. Will you give him oxygen? Yes, his SpO2 is 94 and it requires oxygen. Will you give him a nitrate? He's come to you with crushing chest pain. You will give him 0.3 to 0.6 milligrams sublingual nitrate to relieve the pain. Will you load him with aspirin and clopidogrel? Of course. 325 milligram aspirin, 300 mg clopidogrel, 80 milligram atorvastatin, put him on oxygen, give him morphine and the nitrate. Now that you've done MONA, and you've given all this, you're waiting for the ambulance to come to take him to the nearest cardiac center. What are the expected complications? Can anybody tell me 2 complications that we can expect in an anteroseptal or an anterolateral MI? Anybody with any answers?
Cardiogenic shock, somebody.
Yes. So even though the BP is 166 by 1.
LBF, someone has written.
Okay. So absolutely correct. All of you might find it strange. BP is 166, 110. Why should he develop cardiogenic shock or LVF? Please remember, with high blood pressure, as I mentioned in my earlier slide, in patients with hypertensive crisis, they can develop a sudden decompensation leading to acute pulmonary edema and LVF with a high blood pressure. But the high blood pressure is because of the extreme sympathetic tone. And when that extreme sympathetic tone is lost or the regulation is lost, they can go into cardiogenic shock, especially when there's an extensive anterior wall MI like in this patient. So this is why I said BP every 15 minutes, irrespective of whether you've given MONA or not, you have to monitor the BP every 15 minutes. So LVF with pulmonary edema is one complication where you'll give Lasix. The other complication is cardiogenic shock, where you will not give Lasix, but you will also not give IV fluids because this is a anterior wall MI. IV fluids are only given in an inferior wall MI. The second complication you should expect in any anterior wall MI are arrhythmias, atrial fibrillation, ventricular tachycardia. Case number 2. An elderly woman who's a known diabetic comes to you with fatigue for 1 day, had 1 episode of syncope, and after that she's very restless, brought in by her bystanders. Her pulse is 56, her blood pressure is 84 by 66 with a normal SpO2, her JVP is elevated. The moment you see this, you do this ECG, and this is what her ECG shows. Can anyone wants to volunteer as to what this ECG is showing?
Inferior wall, LWMI.
Okay, somebody is saying an LWMI.
IW, sorry, IW.
IW, okay. That's an inferior wall MI. You're absolutely correct. There's ST elevation in 2, 3, and AVF. But if you look carefully, there is ST depression in 1 and AVL. And strangely, there's ST elevation in V3 and V4. Now you will say that V3 and V4 is supplied by the left coronary artery. 2, 3 AVF is supplied by the inferior wall supplied by the right coronary artery. What all of you must look at in this ECG, can all of you see this black symbol here? This black symbol is actually the small letter R. R stands for right ventricle. This is a patient whose ECG has been done with the leads not on the left side of the chest, but on the right side of the chest, because when you see an inferior wall MI, you must always also ask for right-sided leads. So where you placed V2, V3, V4, V5, V6 on the left side, in the same positions, if you place it on the right side, you will add an annotation of R, which is the right-sided lead. So this is showing V3, V4, V5 ST elevation in the right ventricular leads, showing you that this is just not an inferior wall MI, but also a right ventricular wall MI. So your diagnosis is actually inferior wall MI with RV MI. That explains the bradycardia because there is AV dysfunction. It explains the hypotension. It also explains the raised JVP. So how will you manage this patient? You will still give MONA? No. Morphine in hypotension is controversial. You will definitely not give nitrates. You will give oxygen. You will give aspirin, clopidogrel, and atorvastatin, but you must give this patient IV fluids. Now you will say, sir, the JVP is elevated. She's got right heart failure. Why are you going to give IV fluids? You're giving IV fluids to maintain the perfusion to the left side of the heart, irrespective of the status of the pulmonary vessel. So you will give IV fluids to maintain the blood pressure. If a bolus of IV fluids does not work, you will start inotropes, noradrenaline in this patient. Now, what are the expected complications in this patient? Can anybody tell me 2 expected complications in an inferior wall MI?
Come on, Vinay, you're answering so many of the questions. You think brady and hypotension.
Very good. You already got brady and hypertension. In addition to what I've put up, can you tell me of any 2 complications? Shock, yes. So extensive right ventricular MI can cause shock because not because the LV is affected, but there is no blood going from the RV to LV. Can anybody else think of one dreaded complication of a right ventricular wall MI? The right ventricle, the outlet of the right ventricle is a very big artery, which is very important for us, the pulmonary
Rupture,
artery.
somebody's written rupture. Rupture off and then just left it. I don't know.
Okay.
Shruti, rupture of what?
Free wall rupture of the right ventricle is rare compared to left ventricle. But the actual answer is when you have a right ventricular MI, it can lead to the formation of a thrombus which can disseminate into the pulmonary artery. And pulmonary embolism is something which can occur in a RV MI because the hypokinetic RV commonly allows clots to form, which is why giving heparin in these patients can often save their life. So RV MIs can have both cardiogenic shock as well as pulmonary embolism. A male patient admitted to you with who's a lone case of COPD is admitted for pneumonia. You get a call, you're the duty doctor, you've been treating him for the last 3 days. They call you saying suddenly he's got chest tightness, dyspnea, and desaturation. You notice that he's tachycardic with the normal blood pressure, he's tachypneic with a respiratory rate of 30, his saturation is only 88%. This is his ECG. You look at this ECG, if you look carefully, you'll be able to pick up some subtle and some not so subtle findings. Is anyone willing to volunteer what we're dealing with here?
Inverted T waves.
Yes, so there are inverted T waves in V5, V6 as well as 1, 2 AVF. You can also notice
Depression.
Yes, exactly. ST depressions.
Shruti is downsloping.
Perfect. Downsloping ST depressions in V5, V6. ST horizontal depressions in 1, 2 and can also be seen. And this is classically non-ST elevation MI. Why is the patient having an NSTEMI? COPD and pneumonia in elderly patients are known causes of developing NST MI due to the oxygenation mismatch between the oxygen supply and the myocardial perfusion. What will you do? MONA. Now, again, here with respect to MONA in NSTEMI in a patient who has pneumonia, I would not give morphine. If they're having tachypnea because of an underlying consolidation, I would avoid morphine in this patient because it can cause respiratory depression and thereby affect the dynamics more. Oxygen, of course, nitrates, yes, aspirin, clopidogrel, and atorvastatin. I would also add, because this patient is COPD and pneumonia, he's going to remain in your hospital. You will then follow the protocol of giving him unfractionated heparin, subcutaneous or IV, Q6 thoroughly. What are the expected complications in this patient? The NSTEMI can progress to cardiogenic shock or pulmonary edema, especially in a patient who has an underlying COPD. The last 2 cases for today. A young hypertensive comes to your ER, and this is something that I have found on numerous occasions, both in my OPD and referrals from our bond centers. Retrosternal burning and reflux classically after a spicy meal. And he says, I'm feeling some mild chest discomfort. Vitals are absolutely fine. Systems are normal. Saturation is normal. You do this ECG.
Whoa.
This is a photo of an actual ECG that I got from one of my colleagues. And if you look at it, prima facie, the only thing that you can see are, can anybody tell me what they see?
Oh my God. R.
Yes, you may not see R waves in V1 to 3, but what you should look at, which is staring at everyone in the face, are these giant T waves. And you can also see some amount of ST elevation starting in V1. This is the hyperacute phase of an acute myocardial infarction. So if you can pick up in this phase, that it's a hyperacute phase, load the patient with, again, he's not come to you with severe chest pain, so you may not need to give a nitrate, but give everything, or morphine, you may need to give nitrate, but not morphine. Load him and refer him immediately. You might actually save myocardial tissue. So this takes a great index of suspicion to pick up hyperacute T waves. And the last case scenario, which is again something which is unfortunate but is seen, passers-by bring in an unresponsive patient who's been unresponsive for the last 15 minutes. They carry him in. They notice that just before he collapsed, he clutched his chest, vomited once, and collapsed to the floor. There's no pulse, no BP, no saturation. You immediately start trying to do CPR, but smartly you get an ECG done quickly, which shows this. And then you look at your colleagues and say, my God, there's no pulse, but I'm getting ECG findings. Can anybody tell me what this is called and what type of ECG this is?
VF.
Ventricular fibrillation.
Yeah, VF.
Yeah.
VT, somebody's written.
Yes, this is actually the phenomenon called PEA, pulseless, that's no peripheral pulse, electrical activity. You have ECG showing electrical currents, but no peripheral pulse. If you look at this carefully, this is actually ventricular tachycardia. How will you treat this patient? You will follow the ACLS protocol. While you should load him, put a Riles tube and load him, your priority is ABC here, or CAB as it's become. You will start him on CPR, or you will follow the pulseless electrical activity protocol where we have to give either DC shock or CPR based on what you see. Please remember, the loading doses here are secondary. Your primary goal here is to get a palpable pulse. So please follow the ACLS protocol. This does not mean that they are not having an underlying MI. Once you re-establish a pulse, put a Riles tube in and load them with aspirin, clopidogrel, and atorvastatin. Of course, morphine and nitrates will definitely not be given in such a scenario. So my conclusions are Pele, P-E-L-E, after the famous footballer. Prompt diagnosis of an ACS with a high index of suspicion, which may necessitate you to repeat an ECG if you're suspicious. E for ECG and cardiac markers, which must be done. L for loading doses, which once you confirm the ACS, aspirin 325, clopidogrel 300, and atorvastatin 80 with or without nitrates. And the last D is early referral to a center which is capable of doing PCI or a place which has a CSU willing to do thrombolysis. If you can follow these steps and you can follow the algorithm that I put up for you, managing ACS becomes that much easier. My conclusion, time is myocardium. And once again, thank you everybody for logging in, and thank you to the Alumni Association for allowing me to present today.
Now you can put on your video.
Yes.
Excellent, Chaitanya. Oliver, you want to say?
Yes. Thank you very much to both Dr. Chaitanya and Dr. Jobin. It was a long session. Thank you for all of you for sitting and sharing it with us. And do you all have any questions?
I hope this has been useful, and I can see a lot of sister doctors who have been logged in for quite a while. So I think it was something extremely useful. I found it very interesting and very practical, and I like the mix of case studies that were put in, and for both the presentations. So I think this was a very nicely done and very, very useful set of topics.
We also will be getting the PowerPoint presentations from the speakers and have that circulated to you, especially the snake bites. I know many of you all would want those. So that will be done and sent out in the same channels through which we send this out. Okay.
So the people are saying it was useful, very informative. So a big thank you again to Dr. Jobin and Dr. Chaitanya. And Oliver, can I ask you to close the session?
Yeah. Thank you very much, Dr. Chaitanya and Jobin. It was a lovely session. We learned a lot, and we're getting a lot of feedback saying that it was a very wonderful, informative session. Thank you very much. Thank you to
good teachers. Okay,
yes.
very careful. You kept our attention right through, and you presented your slides very nicely. So those are signs of good trainers. So keep up the good work, and I hope you're all safe. I know you're busy in CCU things. So thank you to all the participants who've attended. I know it was a long day, evening, but I hope it was useful. And like Oliver said, we will be sending out these presentations to you so that you can get more time to go through them. And you're most welcome to continue to interact with through Oliver if you have questions or doubts, and then he can keep in touch with both Jobin and Chaitanya to answer them.
And a note for the next topic that we will be having a talk is on dermatology. What we will be doing is we will be sharing an email ID to which all of y'all can send any dermatological queries that y'all have, any doubts or any topics that y'all would like to be discussed. The talk will be scheduled and made tailored to what y'all send in. That will be shared with y'all as soon as we can. All right. So thank you very much to all, and good night.
Thank you.
Thanks again, Chaitanya and Jyoti.
Thanks, Chaitanya.
Thank
Thank you
Thanks,
so
Jobin.
much.
Thank
Thank
you.
you so much,
Oliver,
everyone.
good job
And
done.
thank you very much.
Thank you, Tony, and the tech team over there, the Zoom host team. Thank you very
Yes.
much for everything.
Thank you so much. It was such a great opportunity. Thank you.
Nice, very well done.
Thank you,
Thank you
sir.
for the
Thank you.
opportunity.
Thank you.
Yeah. Bye, Oliver. Bye.
Bye. Good night.
Good night, everyone. Good night,
Night.
Oliver. Thank you.
Stay safe.
Bye-bye.